I am pleased to introduce my colleague and co-conspirator in this whole meeting, Steph Bertozzi, recently the Dean of the School of Public Health at Berkeley, and before that at the Gates Foundation in charge of HIV and other areas, and before that at the Institute for National Health, INSP, in Mexico, where he ran the economics unit. Steph proposed, and Dean and I agreed, that we will do this in the Davos format of interlocutor. Steph.
I'm not going to spend a lot of time introducing Dean. You already heard that the university has just honored him for being extraordinary. And he's here today because of a very long history of involvement with exactly the issue that we're talking about here. And in particular, the fact that he has led now 3 different waves of the Disease Control Priorities Project. And that was after he did an undergraduate degree at Stanford. And fortunately, we're partnering with Stanford, and even though I'm from Berkeley, I can be proud of that. And then went and studied at Harvard, where he did a PhD with Ken Arrow, who then got a Nobel Prize. And I first met Dean when I was working at the World Bank, and he was my boss's boss. And one of the things I did when I was working for my boss was meet over at the time, and this was while I was pursuing my doctoral degree, was to support the work that Dean and others were doing on the precursors to the Disease Control Priorities Project, and what Dean was also responsible for at the World Bank, which some of you are old enough to remember, which was in 1993, the World Bank published the World Development Report on health. And I think that in my professional lifetime, that was probably the most important single document in terms of changing the orientation of global health. So Dean has been at the center of the debate that this conference is about for a very long time. And I thought that it might be useful to spend a little bit of time talking about where we came from, those early days. What was the first DCP3, and in conjunction with the World Development Report, the desire to develop measures, DALYs in particular, that captured both morbidity and mortality. Tell us where we were back then, before we get to where we are today. And I'll just preview by saying that I had a discussion earlier in the week with Dean, and he's wondering whether we're now in a post-DALY world. So I'm asking him to explain the beginning, not because we're necessarily going to remember it with rose-colored glasses, but really so that we can end up talking about how different the world is that we're in today. So Dean, where were we back then, and how did this all start?
Well, during the time you were working in the group that I led, there were 2 very substantial pressures on me, or at least that I felt, in terms of how I allocated the limited resources of my division. One was, in the early 1990s, AIDS was really discovered in the major newspapers, and of more relevance to me by my managers in the World Bank. So do more about AIDS, Mr. Jamison. And the second was my own personal experience previously having worked on China for the bank, to see the emergence of a non-communicable disease agenda for which I felt the public health community had no clear response. So DCP1, initially an internal World Bank review, was an attempt to place responses to the AIDS epidemic, responses to the then still pretty well unrecognized importance of NCDs in low and middle income countries, to try to place that into a broader context using cost effectiveness.
And what were at the beginning there, tell me about how that translated into the World Development Report and what you think changed in terms of global discourse.
I think gets a lot to just the last discussion around how cost effectiveness or economic evaluation more generally has been and can be used. And I personally started off with a very clear set of objectives for that, which was to help inform intrasectoral resource allocation, to think about the trade-off between NCD prevention, treatment of malaria, the whole range of things, and to balance across the health sector using cost effectiveness. And that, I think, really didn't happen at all, or if at all, in a few select examples, perhaps to some extent in Mexico where you were involved. What I saw instead was two kinds of uses. One, I'd call it low-hanging fruit, from the first round of disease control priorities, tuberculosis treatment. Another related in the World Development Report was a sense that treatment of infection was likely to deal with a much larger fraction of the burden of infection than prevention at that time, at least with reasonable resources. So it was kind of low-hanging fruit and stimulation of discourse within professional communities. I think particularly of my own experience with the cardiology community, they began to discuss in a serious way, how do you respond to a very large volume in many countries, middle-income countries, of mortality from heart disease and stroke, with resources that were on the order of a tenth or a hundredth of the per-person resources available in France. And I felt that the cost-effectiveness discussion provided a useful stimulation within these communities, a starting point for intra-community discussion about basically how to do their jobs better. So those were very different outcomes than I had expected.
Now, some of the pushback back then was alluded to by Elliot and Eric in the previous session. There was one that wasn't mentioned, and I remember that Jeff Hammer, a colleague at the time at the bank, because one of the consequences of pointing out the comparative cost effectiveness was that things at the primary care level tended to look better than things at the tertiary care level. And yet, developing country governments were disproportionately investing in hospitals and not so much in primary care. And Jeff pointed out that one of the rational reasons for that was that governments were protecting against catastrophic expenditures that were impoverishing, and that people supported those policies because they felt they could handle the day-to-day stuff themselves, but they couldn't handle serious illness. I think other blowback came from the kinds of things that Elliot pointed out, and I'd like to get into some of those, but I use that as a lead-in to wonder, what do you think, looking back, we didn't do enough of in DCP1, and how did that move us toward DCP2? What did we try to fix? Did we try to address Jeff's issue? What other issues did we try to address as we moved beyond the first whack at this problem?
So I think Jeff Hammer was quite correct to observe that in the first iteration of disease control priorities, we didn't look at how the financing of the interventions that we thought were attractive would affect financial protection, and how financial protection concerns might importantly affect the selection of interventions. Some interventions might buy more cost effectiveness. I didn't personally pay a lot of attention to Jeff. Frankly, he's not my favorite guy, but for more substantive reasons, it seemed to me that the first priority was you're getting these buys, capacity to buy mortality reduction and human welfare improvement at extraordinarily low prices. That people, yes, it's fairly inexpensive, but poor people couldn't buy that for themselves, and also didn't often know the option was there. Maybe they didn't have the option without centrally developed programs. So I felt that the financial protection issue was genuinely secondary. And we didn't deal with it. You were engaged with DCP2. We picked it up, and we can return to this, but in DCP3, we've taken the question of financial protection. We took it a lot more seriously. We made some progress, not a lot, but the failure of, in my view, a community of World Bank economists and other academic economists to move beyond the observation that financial catastrophes tend to occur at the hospital level more frequently than at lower levels, and therefore the right place for government money to go is at the hospitals. That was a simple assertion, undocumented by an examination of where financial catastrophes, condition by condition, which we still don't know, came from. And even more, there was no attention paid to, if we're worried about financial protection, how do you most efficiently buy financial protection with $1 million of government money? There was no efficiency discussion at all. And we, I think, in DCP3, moved toward trying to get some answers to those questions.
Now, the other pushback that I remember, and I remember being almost run out of town on a few occasions, by my fellow physicians, who in some cases were quite violently against the idea that efficiency should be guiding the choice of which medical intervention should be funded. In Mexico, we did a study. Pneumococcal vaccine is recommended by the CDC for children to be given at 2, 4, and 6 months of age, and another booster at 12 months of age. Since almost the entire mortality burden for pneumococcal pneumonia in children occurs before 12 months of age, and even after 12 months of age, the protection from the first 3 doses is very good. The additional benefit for that 4th dose is very little, and the cost is a quarter of a 4-dose sequence. So we made, I think, a very compelling argument that it was not cost effective, and it was done in conjunction with Norman Hurst, an ethicist at Harvard. And yet the National Immunization Council voted 20-1 against the recommendation that Mexico not implement the 4th one. That's similar in Malawi to having the National Organization of Urologists recommend that only urologists should do adult male circumcision as an HIV prevention. In other words, my suggestion is that elite physicians in countries are often a very important obstacle. That's what Elliot alluded to in this emotionally we don't like it. Well, emotionally we don't like it meaning elite physicians in countries emotionally don't like it, and that often sets policy. Did we do anything to try to address this pushback from the medical community to the concept that basically to what I would say is almost the revealing of the opportunity cost of the decisions that we're making? Maybe that's a question for Eric more than for you, but I'm curious about how you were thinking about it.
So I was thinking about 3 communities of pushback. The 2 you mentioned, the professional elites, and what I characterize as the free market romantics, the people like Jeff Hammer who somehow think you can bring free markets into generating efficient and equitable resource allocation within a health system. So that romanticism exists, but it's much less of a problem today. But in addition to those 2 groups, there'd be what I'd call the public health left, which was just totally opposed to thinking seriously about budget constraints and felt that you had to do what was right, and what was right was what could be done. I mean, that's often put almost that starkly. So in your examples, I think it was both that and the elite resistance. On the dealing with the elites, that's a political issue, and to some extent we decided as we went to the 2nd edition of Disease Control Priorities, where Jaime Sepulveda chaired our advisory committee, but we decided to have an advisory committee that was importantly representative of the medical and scientific elite from around the world, that was generated by representatives from the world's academies of medicine. And there was a lot of debate about that, because some of my colleagues felt, well, these are a bunch of scientists and hotshot clinical doctors. What do they know about, dealing with the real problems out in the rural countryside? But I think we made a little bit of progress on the political question you raised, the political economic question you raised, because people in this community, I think, began to look from our perspective, from our public health perspective, more seriously at these issues. But also, there was a lot of valuable technical input from the scientific community. So, but I think that's going to be a long discussion. We had that in surgery with Haile DeBaas, and his leadership in globally as a surgeon was important, not really everywhere decisive, in having surgical communities accept DCP-3 findings around surgery, DCP-2 findings around surgery, that the substitutability between mid-level providers and highly trained surgeons could be quite high if the middle-level providers were fairly narrowly trained on frequent problems. And you could save a lot of money, but that was going to cost the professional communities. So it's having leadership like the clinical leadership of Dr. DeBass dealing with these professional communities much more than having some UCSF economist, frankly.
So if we maybe think about the two steps forward after that into DCP2 and DCP3, what do you see as the things that we have managed to fix, and what do you see as the unfixed agenda? More from a methodological or technical perspective, what do you think we've managed to improve, and what's still missing?
So I think a couple of important improvements in DCP 2 and 3 and how we approach things. One was to think of packages of related interventions, related in the sense that they were dealt with by a professional community: surgery, cardiovascular disease, under 5 mortality, child health.
By a community or by a place or an entity?
By dealing with by a community, I was thinking kind of thought about policies thought about by the cardiologists or the surgeons, and to have them looking across surgery, across cardiovascular disease. So instead of an intervention by intervention look, there was a cluster look of both what the health system could do and what factors, policies outside the health sector could accomplish. And I felt that was a useful response to, if my observation was correct, that professional communities were really an important part of our audience, a part of this mediating that Eric talked about between analysis and actual resource allocation on the ground, that engaging them through these packages. The second...
but before you leave that one,
sure.
Let's just take a concrete example. You get a bunch of experts in diabetes together to talk about diabetes management, and now you also want them to think about soda taxes. In retrospect, did that work? Did we get the right community together?
I think to some extent it worked. I mean, if you take what you're very familiar with in Mexico, a scientist like Juan Rivera, a nutrition scientist, was really the force, as I understand it, behind the soda taxes, sugar-sweetened beverage taxes in Mexico. And so it's often, I think, working the economics in this case through the scientists, through the elite clinicians, through the leadership of the medical community that can have a political effect, or it's a different channel for political effect.
Yeah.
A finance minister likes soda taxes too, on the whole. So I mean that's a different community and for different reasons. But I don't think it's a settled story. I think it's an improvement to try to look at these together. The other major step that we took was to try to deal with this bundling issue or aggregation issue that the anesthesiologist colleague raised. And that's an issue that arises at multiple levels. I mean, is anesthesia, should you be thinking about anesthesia separately from surgery? My answer is unequivocally no, that there's a package of activities around a surgical procedure that includes a bunch of things, and it's you let the technical people figure out what the right things are, and then it's that package that gets that intervention, that surgical procedure. Or you can go up one step from that, and here Haile DeBass's work in DCP2 was quite influential in the thinking of the rest of us. His argument, correctly, I think, was that surgeons' surgical capacity goes well beyond single procedures. Governments don't buy appendectomies. They buy surgeons, they buy anesthesiologists, they buy surgical wards, they buy a cluster of things. And so that higher level of aggregation into platforms was very constructive, I think, in looking at surgery. So we really almost entirely stopped looking at individual surgical procedures, not completely by any means, and looked at the surgical ward of a district hospital as a single entity, really. That notion expanded in DCP3 to kind of thinking about what we ended up with was 5 platforms of delivery, basically levels of a health system, district hospital, a major community health center, referral hospital. So 5 levels of a health system, and to think of interventions as positioned somewhere on those platforms, but to have a good economic analysis by platform was a natural next step that we didn't take. So we did the descriptive relationship of interventions to platforms. But beyond the surgery example, and I think emergency care is an example, we didn't really do analysis at the platform level, and I think it needs to be done.
Well, I remember one frustration. I worked on the HIV chapter for DCP2 and worked fairly closely with our colleagues who were working on the family planning and maternal health parts of DCP2. And one of the frustrations was that I was dealing with HIV, and condoms are effective at preventing transmission of HIV, but the STD chapter was looking at condoms because they're also effective at preventing the transmission of multiple sexually transmitted infections. And then the family planning group was looking at condoms because they also prevent unwanted pregnancy. And one of the frustrations was that each of us were coming up with numbers, cost effectiveness, prioritizing within our scope without considering those other benefits. And in the case of preventing unwanted pregnancy, we were having trouble capturing that at all. Mm-hmm. Do you think we've made progress with respect to those issues?
This, in my mind, gets a little bit back to the question of whether it's gotten to be time to retire qualities and dallies substantially from discourse. And that's...
I told you guys would get there.
not quite planned. But what you have with investing in contraception is, there are clearly medical benefits. But the principal reason here is to enable families to help regulate and choose the family size they want. It's family planning. And that's not a health consequence. I've been working with Dave Watson recently, who has the costing models for DCP3 on the question of how much of the essential packages, how much of the definition of universal health coverage within DCP3, what fraction of the money goes to completely non-medical outcomes. So you have a medical investment, UHC, and for some important subset of that, 14 or 15% of the money goes for family planning and for a series of palliative care, a series of investments that do not have outcomes that change the burden of disease metric at WHO or the IHME. And then you have interventions that affect under 5 mortality or over 5 mortality, disability of different kinds. So Dave looked at how resource allocation was spread across those objectives, and it just seemed in some sense that there was not a very large range of things, but they included a number of non-health things like family planning, where a couple of years of protection might be the effectiveness measure rather than anything like a health measure, that creating a dashboard of mortality at 2 or 3 different ages, reduction of mortality at 2 or 3 different ages, identifying the really big sources of disability and morbidity. And there are lots and lots, but the really big ones are fairly limited. Psychiatric disease is probably the largest. Deal with those one at a time. Deal with the non-health outcomes one at a time. Establish efficiency, value for money along each dimension, and then turn it over to judgment from there. So in a sense, that would be a complete retreat from the notion that one could use cost-effectiveness analysis with an aggregate measure of population health like a QALY or DALY to give you a useful insight into the content of a health benefits package.
So let me just make sure I understand what you're saying. So there's one big group where morbidity and mortality are well correlated, even if morbidity is a large portion of it. And so DALYs or QALYs doesn't help us very much. We don't reach different decisions because of that. And that you're saying that outside of that, there are relatively few things, and maybe we can deal with them individually, and sidestep this question of, could we have a measure that looks at them all together, right?
Exactly.
So in parallel, I know you've been working on edging the global health economics community to thinking more about cost-benefit analysis, which in some ways is tackling the problem you tried to solve with DALYs in a different way and having a different universal measure. How did what you just said jive with that? In other words, can you take that full spectrum of things, the dashboard, if you will, rather than a single measure, and squish it into a cost-benefit world, or is it similarly divided up in the cost-benefit world?
That's an issue that's going to be on my mind a lot in the next couple of years, and I'll be trying to advance the agenda of collapse, of generating a dollar value of benefit in a reasonable way. There's at least hope that that can work, because in a way that QALYs and DALYs we know can't work, because they're narrowly health-related measures, and they have built into them a set of judgments, value judgments, that a lot of people wouldn't buy. Value judgments around the loss associated with deaths at different ages, and the specific value judgments that the loss of a one-year-old child is kind of 3 times as bad as the loss of a 30-year-old woman. So those value judgments are baked in to the way cost-effectiveness analysis, and the value judgments around the disabilities are baked in. That's leaves that whole domain poorly positioned to do sort of transparent aggregation in a way that the dollar can. It can look at the value of contraception, the value of under 5 mortality reduction, and so on, in principle, and in important ways, mostly around the mortality side at this point. There's good practice. There's a lot that's been done, but to me, it ends up being either a dashboard of real outcomes, dropping the kind of artificial QALY or DALY, or an aggregation of that dashboard of real outcomes by way of dollars into a dollar benefit measure.
So let's take a couple of other examples of situations where the DALYs seem to drop short. One of the things that came up as we were talking is this issue of how do we value intelligence, right? And in an ICD-10 world, you consider low intelligence to be diagnosable below a certain IQ threshold. But how many of us would not be willing to pay to add 10 IQ units either to ourselves or to our children? Is that a measure of health? Well, it's certainly a measure of health if we think about it as nutritional deprivation in childhood led to a 10-point drop in IQ, even if it didn't provoke an ICD-10 code. Are you thinking, is that a really important example? What other examples would you put on the table of being failures of our current DALY system?
In my mind, almost certainly one of the most important examples, the cognitive development and the shortfall between genetic potential intelligence and realized intelligence, the shortfall induced by malnutrition and infection, and lack of stimulation, perhaps, but remediable reasons for this shortfall, which is not well measured, but I think some of my colleagues think it's really pretty large. My guess hasn't been addressed yet. If you wanted to look at the most unequally distributed development indicator in the world, a good candidate for that would be math competence at age 15. So if you looked at the 15-year-old population of the world, gave them pizza math tests, and looked at the distribution of scores on that math test, there would be no development indicator more unequally distributed than that. My guess, I'm certainly highly unequal, and substantially remediable, and of enormous economic importance, according to my colleagues in the economics of education. So this is huge, this one. And as you said, it's not in our existing health metrics. It's IQ below 70 or something like that is a medical problem. IQ above 70 is nothing. I mean, it's just not there. So one could try to redo for ICD 15 and have those guys do it better, but I wouldn't wait for that.
Well, and in terms of, I think I agree with you that I think it's a hugely important issue. If you look at what people actually spend their money on, it's the difference between their current state of happiness and their potentially realizable state of happiness. And I use that just to broadly say anything that is not diagnosably mental illness, but is less than optimal mental state. So certainly if you looked at global expenditures, that would be enormous, right? And not trivial in very poor countries either.
Right, oh, for sure.
And so you could imagine monetizing all of those things, right? You could imagine putting a dollar value on improvement on all these different metrics.
I can sort of imagine it. I see it as an agenda worth pursuing. When you put it that way, it does stretch the imagination a bit.
Well, so then coming back to this question of why not DALYs, if we could have trade-offs for these other benefits in dollar values, couldn't we just as easily think of it as a time trade-off question with respect to a DALY equivalent measure? So why couldn't we say that I'm willing, faced with the possibility of a decline in IQ or an unrealized IQ, I'd be willing to trade off 6 months of life for 5 points of IQ. Why is it theoretically any different to think about squishing things into a dollar measure or using the same tools to squish them into a life year measure?
I think that's a very important question in welfare economics. There's a guy at Harvard, David Canning, who wrote a paper that tried to translate welfare economics from a dollar metric into a life year metric. And the main motivation for that is that the benefit cost analysis in some peculiar concept of a pure form takes as given the existing distribution of income. And the value of adding something to society is kind of the sum of the values of that to rich people, which can be very high in dollar terms, and to poor people. Canning's notion was that inherent life years is not distributed very unequally across people. You might have some frailty giving a little bit of spread to an intrinsic survival curve. But fundamentally, survival is pretty distributed equally. So if you wanted to have an equitable approach to welfare economics, you would switch from a dollar metric to a life year metric. That paper met with resounding resistance in a more pure economics community. Struck me as a fundamentally important paper.
In 1991, or 92, or whenever this was all first starting, it's my recollection that if we were going to deal with the political issues that, the headwinds that we were talked about at the beginning with respect to trying to get opportunity costs into the discussion about allocation of resources, that would be greatly magnified if we put a dollar value on human life or an improvement in health and made it starkly evident that lives were worth more in rich countries than they were in poor countries, and that much of the success of that early work was because we were able to frame it in a non-rich country, poor country metric.
DALYs, qualities,
DALYs, in the case of those two particular documents. And the world has changed. Has it changed enough? And how do we deal with this, the political or the political economy of the shift that you're proposing with respect to moving to monetize these benefits?
I think the world has changed. I think it's less of a political problem than when my then boss at the World Bank, Larry Summers, got close to fired from his job as World Bank chief economist for making comments that related to dollar valuations of mortality risk being different in different places.
That seems like a pattern.
He stays pretty close to the edge, I would say. But I think there's much more openness to discussion, and there's much more of a literature that gives us usable numbers, not about value of life, but rather the value of very small changes in mortality risk. That's what's actually measured, and that's what for most analysis, what we need. One of the things that the benefit cost community, which is very separate from the health economics community, even though a lot of the work they do is put valuation on these mortality risks, dollar valuation on mortality risks. They seem quite unwilling to be clear about whether they're talking about use for resource allocation across countries, say investment in a new drug that would have one investment profile, have a lot of value against certain types of infection, another against heart disease. Well, the value of those investments depends on the value to the people who receive the investments. Are you going to use different dollar values for one group of people or another? I think that this is, in my view, clearly an example of where you do not want to use benefit cost analysis, but rather to use lives. How many lives would be saved? But within a country.
And if you're going to do the lives saved, it'd be nice to have non-ICD-10 mortality benefits also included. Right?
Yes, and I would think mostly to focus on mortality at a couple of different ages, unless it's intervention around psychiatric illness, and then you have to deal with that, or other high disability condition. But if you're thinking about resource allocation in the public sector of a country across roads and agriculture and telecommunications and all of the things that governments buy, and reasonably in most cases should buy, that resource allocation decision can't be made with health measures. It has to be made with measures of the value of another year of education, of another kilometer of roads, of another life saved. And it's here that I think we in the health community need to, for precisely, it was I think Jim who raised the constraints, the new sense of constraints on resources that those of us working on global health need to deal with. In that constrained environment, I think we need the economic arguments for allocation to the health sector, or the right parts of the health sector, relative to other sectors. And so I think we need it now, the benefit cost work.
So I have a couple of questions, and they're pretty standalone, not well integratable, so I'll give them to you pretty straight. Lant Pritchett upset the world in 1994 by saying focus on revealed preferences as the best measure of a value of a service. So what are your thoughts on balancing prevention versus treatment, given what we know about what skews personal valuation, or another way of putting it, why was Lant wrong?
Another one of my favorite economists.
The two most prominent critics of the early work at the World Bank.
I don't take these things personally. I think in some ways he was importantly right. The valuation of things that people are familiar with, reduction in pain, maybe even reduction in mortality. A favorite example of the economists was around itching as very, very seriously concerning to individuals, but not popping up in any serious way in the burden of disease, therefore not cost effective to intervene against. But that's only one input, not an overwhelming input. Kind of back to Eric's comment about economic evaluation. And it's a useful part, but only part of the story. That's the way I feel about the monetary valuation of different chunks of better health that's advocated. But, it's going to bias against prevention. As you know, people are not going to pay for that. They won't express a willingness to pay for prevention. I think it's everybody's feeling. I don't, right?
You don't for yourself, you're saying.
I'm not too good at it, yeah.
Yes, but we are able to have this cognitive dissonance where we don't do it for ourselves, we don't exercise as much as we think we should, et cetera, but we're in favor of societally doing things that make more of that happen.
Yeah. And that would be an example here. Don't do as I say. Yeah.
Yeah.
Don't do as I do. Yeah. Do as I say.
Don't mutter. Walk up.
So I think the point here is on the prevention that we're arguing that while we individually don't do, most of us, all that we should, our advice, do what we say, is still probably the right way to think about things, because we're probably saying pretty close to the right thing about prevention, even if we're not doing it. And that won't get captured by the kind of economics that Lant Pritchett is advocating.
The next comment is the question is more asking you as an oracle, I think, in terms of the future role.
I charge for that.
the future role of technology, and the question is really about can technology, especially information technology, which is so low cost at very large scale, potentially be transformative with respect to health, and what should we be doing? Is the next wave China and India taking over the world by using apps and other things that will transform health in a very low cost way? I mean, what is your sense of how technology is likely to affect us going forward?
Information technology.
Well, that's the specific question, but I think that I'm putting it in a slightly broader context because I think that it's information technology on the one side, but also where might we be going with biomedical technology, personalized medicine, et cetera. So what is your sense of for DCP4, will the world be different?
Well, on the information technology, I think it's pretty obvious that no amount of information is going to be useful without drugs or better advised procedures. So that the medical technology is the heart of it. And electronic information technology might help with the delivery of medicines, but the really important area of technological development is going to be in medicine and vaccines and diagnostics and medical procedures. And I think we've probably had most of the low-hanging fruit there.
But you don't see that, I mean, in any one of a number of areas, but for example, if sensor networks tell us where pollution is that is creating asthma in children, and now we can do that cheaply, easily, and remedy the things that are causing our problems. Or if sensor networks reveal chemical exposures in our food supply, water supply, or whatever, or if activity monitors tell us about, or if traffic monitors mean that we don't, there are many determinants of health that are potentially influenceable by information technology.
And I wasn't thinking of that, and I think those are good examples. So one of the things we're working on now is, a month more lead time on dealing with pandemic influenza is worth an awful lot. And if you have the sensors, in a broad sense of the word, out deeply into the environment that buy you an additional month, that's going to be worth an awful lot. And
or even if just Google Flu gives you a sense of an outbreak before you otherwise would report it through the system, right, that obviously can be helpful. So now turning it back with real microphones as opposed to written notes. Anybody, we've got 5 minutes left. Would anybody like to raise any questions, especially if you disagree with Dean, because that's always more interesting.
I have a question.
Jim.
Dean, can you comment on the virtue or lack of virtue of continuity? Kind of path dependence. We've used DALYs for a long time. People are familiar with them. Do we lose anything by shifting to a measure which may be technically better, more inclusive in particular, but it's a big shift. I mean, you helped create DALYs, and you helped create the buzz about DALYs. It has arguably greatly advanced global health efforts over the last several decades. Are we at risk of losing a bit of that, confusing people, if we shift to something which may be technically better, but is less familiar?
But as you answer that, please comment on the fact that today's DALYs are not your mother's DALYs.
Right. So I think what you're referring to is the DALYs that the economists use for cost effectiveness work are very different from the DALYs that are today used in burden of disease assessment. It's the same four letters, but really very, very different constructs, and it's not widely appreciated.
And say why for people who might not understand exactly why.
So the DALY...
I want to remind people what DALY stands for.
Okay, a DALY is a disability adjusted life year, a very close cousin of a British concept or a East Coast concept of a quality adjusted life year. So think of it as life years modified by health status, modified downward by bad health status. And those can then be used in two important ways. If you have that construct, one important way is by aggregating loss from death at different ages and loss from different types of disability. One can have an aggregate measure of the total burden of disease and of the composition of that total burden across individual diseases or risk factors, and that's a useful thing to do. And you have a metric for assessing the effectiveness of interventions in very different environments, the effectiveness of interventions to control childhood infection versus to reduce the risk of AMI. And so it has that, the virtue is in this aggregation. I think that is a capacity for aggregation in those two domains. And those two domains, as I said, are now using quite different DALYs, quite different numerical values for their DALYs. But Jim, where I wouldn't go first to replacing DALYs with dollars. I see that as a long-term agenda to be probably partially implemented and not clearly going to succeed. So I would advocate replacing it with very well-known constructs like age-specific mortality rates and condition-specific morbidity, and using those real outcomes in cost-effectiveness analysis rather than this, what I now view as not quite so useful aggregate. So, and cost-effectiveness work should be doing that anyway, of course. Surprisingly, a lot of it does not. It just switches to DALYs, and it's hard to communicate. A lot of people don't know what they are, except, as you said, it's also quite true that the community of younger health economists, that's the metric of discourse, either qualities if you're across the Atlantic or DALYs here. And so it would be a big change. I think it would be a constructive one.
All right, and with that, we're out of time because it's time for a break. So I just want to thank Dean very much and for letting me do this with him.